Good morning, or actually good afternoon. My name is Brian Meyer. I'm at West Point, Pennsylvania, Merck & Company. Our facility is located northwest of Philadelphia. And today I'll be talking to you about the evaluation of Zostavax, our vaccine for preventing shingles, administered via the intradermal route. Dr. Hanna talked about the intradermal route, and that's why I had asked that question. We'll talk about the administration of this vaccine via this route using a device called the Micron Jet from Nanopass Technologies. Okay, so just an overview of the presentation. The first is I'll talk a little bit about Zostavax, what the vaccine is, a bit about intradermal vaccine delivery using the Micron Jet from Nanopass Technologies, as well as I'll show you a histological section of human skin and device depth, which we believe is important for proper immunization via the skin. We'll talk about preclinical considerations and studies, as well as the clinical design and outcomes of the study. I'll go over the geometric mean titers, the ELISpot data, some safety observations as well, and conclusions. So to start the presentation with respect to Zostavax, it is the vaccine to prevent shingles. Those of us who have had chickenpox, the virus hides in our nervous system, and we can get reactivation of the varicella virus as we age. This vaccine will help prevent that reoccurrence. Essentially, it's a vaccine that contains a more concentrated form of the Varivax vaccine that's given to children. It's administered to older adults, 50 and older. I'm about 5 years or so away from that, so now I'm being called an older adult. I guess that's the way it goes. The way it's presented is in a lyophilized cake. So we have the vial here. We have a lyophilized cake. You take diluent, which is supplied as in a separate vial, liquid vial. You take 0.7 mLs of that diluent and you reconstitute the lyophilized cake. You then withdraw the vaccine and administer 0.65 mils via the subcutaneous route. So essentially what the healthcare provider will do is they'll pinch the back of the deltoid and do a subcutaneous injection. And that's a single dose, single shot for life. So what vaccines are given intradermally? Zostavax isn't given intradermally. Obviously, that's what we investigated. BCG, we know, is given intradermally via the MAN2 technique. And the MAN2 technique is the most common technique that's used for giving intradermal shots. And it requires training on the part of the healthcare provider. Dr. Hanna mentioned that as well, training the clinical staff to give a proper MAN2 injection. I myself have had several tests, for example, for TB, and I can tell you a few different times the bleb looks a little bit different depending on how the healthcare provider does it. So we want something that's more uniform with respect to intradermal administration. We think the Micron Jet has done that for us. The Fluzone intradermal shot, this shot is provided as a pre-filled syringe. I myself have had this flu shot at the pharmacy locally where I live 2 years in a row now. I've opted not to get the intramuscular shot, but rather this intradermal shot. And there are several rabies vaccines that can be given intradermally. So for example, if you need to do dose sparing, you can put that rabies vaccine in intradermally and get perhaps more doses. Other vaccines are being investigated, obviously, via the intradermal route. This is just one example, and if you go to www.clinicaltrials.gov, you type in intradermal, you can see a number of clinical trials are ongoing with intradermal delivery and adjuvants, et cetera. Again, we looked at the intradermal delivery of Zostavax. So here's the Micron Jet. It's made by a company called Nanopass Technologies in Yodam Levin, the CEO of Nanopass. We've worked closely with him in using this device in the clinic. Essentially what it's composed of is a polycarbonate hub. On the top of the polycarbonate hub, you have 3 silicon needles. These needles are made using technology from the semiconductor industry using an etching technology. These needles are only 600 microns in length. And here's a blow-up of what the actual needle looks like. You can get very nice etching of the silicon as shown here. It's very symmetrical with a hole through it. Essentially, it attaches to a lure lock on a typical syringe, We like the Lure Lock because it holds the polycarbonate hub in place. So essentially what you do is you take the vial that has the reconstituted vaccine, you withdraw it with a needle syringe, remove the needle, place on the Micron Jet, clear the air, and then inject it directly into the patient's arm, giving you an intradermal bleb. And it does target the epidermis, which I'll show here. This is a histological slide of human skin. On the top here, you see the stratum corneum, or dead cell layers. Here you have the epidermis, and in the epidermis, as Dr. Hanna had indicated previously, the epidermis is rich in Langerhans cells and dermal dendritic cells, especially here on the papillary dermis. And then you have the reticular dermis, which is deeper. And what you can see here with the MicronJet is you're targeting the shallow epidermis, which is where the Langerhans cells reside. So the concept is you place antigen here in the epidermis, and then you get active transport of the dermal dendritic cells to the draining lymph nodes. If you look here at Fluzone Intradermal, the shot that I had mentioned, the flu shot that I have gotten the last 2 years, and by no means is an advertisement, but I actually just like the intradermal shot better than the intramuscular shot. You can see it's a 1.5 millimeter needle. It goes deeper into the reticular dermis. So I think what's going to be interesting in this field is to determine whether the depth of delivery is important for intradermal delivery, and if you're targeting specific cell populations depending on where you place that antigen. I think this is something that could be quite interesting to explore in the future. So what did we do in preparing for the clinical trial that we did? This was an experimental medicine study. As I mentioned, this is the subcutaneous control that we had. We administered Zostavax intradermally with several different doses. We titrated down. Essentially, we had the full dose, 1/3, 1/10, and 1/27th dose. The full dose was obtained by reconstituting the vial that we have now right from manufacturing in a very low volume of 0.35 mils. We took 2 of those injections and put them into the skin side by side with the Micron Jet, 150 microliters per injection. That's generally pushing the limit for a bleb for an intradermal injection, at least with this device. The more typical volume for an intradermal injection is 100 microliters. For the 1/3 dose, we reconstituted in 0.3 mils, administered 1/3 of that, 0.1 mil. 1/10 of the dose, 1 mil of water, administer 1/10, and then in the 1/27th dose, which is a very small amount of Zostavax, we reconstituted in saline to maintain the tonicity. This much water would have been hypotonic. We did perform syringeability studies, so I have some experience in another field in therapeutic monoclonal antibodies, and we look at material compatibility. So I brought that training back to vaccines, and I said to myself, well, we want to make sure that the syringeability doesn't change the vaccine. We're putting it through a new device. This is not a needle. A needle would look this large, whereas the Micron Jet would look this big. I wanted to make sure that there was no shear of the virus or damage going into the body, because that would have altered our clinical results. And essentially, we actually had no issues with the Micron Jet. Everything looked very good. Potency looked very good. So the clinical design was as follows. We had 221 patients enrolled at 3 clinical sites in the United States. It was a partially blind randomized trial. We looked at immunogenicity and safety of Zostavax. There were the groups I had already mentioned: full dose sub-Q, 1/3 sub-Q, and then full dose 1/3, 1/10, 1/27th. We did not anticipate to see any results with respect to the 1/10. We tried it, but we really weren't expecting anything major to come out of this. That's why we didn't do the 1/10 to 1/27 sub-Q. Turns out, as science always does, it would have been good to have those controls because we did see a response. Again, sometimes you get good things coming out of studies that you're not expecting. We did geometric mean titer of antibodies as well as ELISpot to look at T-cell responses. So the first piece of data that you're going to see now is the titer geomean fold rise. Essentially what you're seeing here is the geomean fold rise above baseline. So these patients obviously had chickenpox as kids, and they had a baseline. This is the titer following immunization for the first time with Zostavax full dose sub-Q, which you can see here, anywhere from 1.5 to 2-fold geomean fold rise. With the Micron Jet, we had a much more significant effect than with the sub-Q dose. In fact, we broke through the ceiling of the G-mean fold rise. This is higher than we've ever seen. So this was very exciting to us in the fact that the ID administration actually gave us a really, really strong response, and we actually broke through the ceiling from what we had seen before. This was very, very exciting. In fact, this data came in when I was at a conference in Ireland, and I can say I was pleasantly surprised with the results. A third of the dose, sub-Q, you see a very similar result for full dose. This makes one wonder, could we put 1/3 of the amount of the vaccine and get the same response? If so, from a manufacturing perspective, you can get 3 vials for 1 if that were the case, but we are sticking with our current licensed product. If you put in a third of a dose ID with the MicronJet 1/10 or 1/27, you still get a very good response. So what was really interesting here is that we saw, even at a 1/27 dose, we were very similar to what we saw with the full dose sub-Q. That was extremely encouraging. And what we believe is happening is when the attenuated virus gets into the skin, because the skin is a normal place for the virus to infect, you're getting some viral replication. We think that, in combination with the dendritic cells that are located in the shallow epidermis, you're getting this really robust response. So we wanted to know if there was any T cell response. We did an ELISpot assay looking at gamma interferon from the T cells. Again, full dose sub-Q, our G-mean fold rise is here. Full dose ID, we did go higher, but not quite as high as we saw with the G-mean fold rise. But nonetheless, we didn't see an inferior response, and I think that's key. The 1/3 dose sub-Q, again, similar. And now we start to see a drop in the T cell response as we go lower. So perhaps this would be the range that we would be targeting. So with respect to safety, so one hesitation, I think, for companies and individuals to go to the intradermal route for vaccine delivery is how does it look on the surface of the skin? And we know that the customer is very aware of how something looks and how something feels once it's administered. I can tell you with an intramuscular vaccine, I wouldn't call it painful. You do feel that sharp pinch in your arm, but I can tell you after a few days you do feel that soreness in your arm. And as vaccinators, we need to think about how the vaccine is perceived by the public. So the intradermal administrations that I've had, at least with the flu vaccine, I just see a very small red bump, which from a cosmetic perspective doesn't bother me. But nonetheless, we still looked at safety with this particular vaccine. We used a vaccine report card. It was previously validated, and individuals recorded daily oral temperatures and any systemic adverse experiences. They also looked at the first 5 days of vaccination, what the site looked like, redness, swelling, pain, etc. And here are the results for that. And I just want to highlight a few points. That with the full dose ID and full dose sub-Q, we're seeing pretty similar results here with respect to adverse events with 1 or more injection sites. When we look at erythema, we do see an increase here when compared to the full dose, 26 individuals versus 16. We also see more 20 here when compared to the sub-Q dose. With respect to site pain, which I had mentioned before, we actually saw more pain, or there was more perception of pain with the sub-Q administration than there was with the intradermal vaccine, as you can see here and here. Yeah. The question here is whether what we saw here with the swelling or pain was a result of where it was in the skin, in terms of you could see it, the swelling more because it was on the surface of the skin. The conclusions, we did see a higher G-mean fold rise compared to the subcutaneous delivery. We saw enhanced JPLI's results, but we'd have to do an efficacy study to see if the titer actually correlates to efficacy. So giving it intradermally, would we see a better response? We saw a dose response with the MicronJet. We saw a fraction of the dose was just as good as the full dose subcutaneously. We saw erythema again with the ID vaccination, but we saw less pain with the MicronJet. I just wanted to thank everybody, specifically Yotam Levin at Nanopass Technologies, our collaborator, Shan Beals, who did the clinical work, as well as my manager, Robert Evans, and Julie Waterbury in our scientific affairs group.
Thank you. Just an interesting anecdote, but our hospital switched for our flu vaccination from the intramuscular to the Sanofi vaccine about 3 years ago. After 1 year of the experience and having so many complaints of sore arms in staff, they've actually switched back to the standard vaccine. So obviously some people react more than others, but overall the infectious disease staff said they'd never seen so many complainants. So that's just on the other side of the equation. So yeah, maybe you have a good response, but...
Thank you. Yeah, with respect to the intradermal administration and the swelling and the itching, I've heard that as well. And I think one thing that would be interesting to explore is whether it's the formulation, perhaps, that's causing that, or the antigen, or a combination of the two. I think we haven't seen those studies done.
Yeah. No, I think it's early days, but obviously there's a lot of interest in this as an alternative route. Okay. Any other questions? Yes, so... Please.
Thank you very much for excellent lecture. I ask if you made a study on this micro-inject on other vaccines that can give intramuscular and check its result, or it's not. Thank you.
Yeah, so the question was, are we using the Micron Jet for other vaccines? And I can tell you that Nanopass Technologies is looking at administration of flu vaccine with the Micron Jet, and he just published a paper recently on that, showing that shallower delivery is giving a better response than the other deeper administration. I can't comment on whether we're testing other vaccines until they're in the public area. I can't comment on that. But certainly other vaccines are being investigated by Nanopass with their collaborators, which I don't know what vaccines they're using, but I know that they are using other vaccines, yes.
Okay, maybe a question.
I was wondering, you take a standard depth of the epidermis, but of course there are a lot of people with different skin types. Children are different from adults. So what are you always in that zone if you target? And you know the recent studies that in fact the Langerhans cells would be tolerogenic, and the dermal cells are the ones you have to reach to target immune responses.
Yes, so I think everyone heard that question with respect to differences in skin depth, age, and also where the dermal dendritic cells are, which ones you really want to target, the deep ones or the ones that are Langerhans cells, which are more tolerogenic, I guess you could say, or look at, that are for tolerance. So with respect to those questions, there was a study done, I forget, it may have been by Beatty, that did ultrasound looking at skin depth amongst different ages. And if you'd like, after the meeting, we can talk about that publication where they did see similarities actually between epidermal thicknesses and dermal thicknesses. So we can talk about that reference specifically. And I think the question about Langerhans cells versus dermal dendritic cells, in my mind, is still controversial. As to which exact cell type you want to choose. And I think that could be done effectively with FACS sorting studies. So there are specific markers, Langerhans and other cell markers, where you can differentiate where that antigen is going and what type of cell it's going in by using FACS analysis. And again, there have been some publications looking at different types of immune cells in the skin. I know we're out of time. I'd love to talk more, but I'm going to have to go.